safe?
Yes.
Alright, now that my scene is safe, I can approach my patient. Hello, I would ask him his name, as he's doing. I know he's shortness of breath already, but I could probably tell from how he's answering my questions. If he's like, I'm Timothy and all of that, like, as you're walking up to him, talking to him, you're assessing their breathing already. And then as I'm talking to him, I'm probably going to grab his hand like, sir, is it okay if I take your pulse? So while he's asking me my questions, I'm counting in my head, looking at my watch, taking his pulse for his pulse, which is 108. So now I have a pulse of 108, which is in the normal range. Not really too concerned about it. It's not super high. It's not very low. So now that I got his pulse, I'm going to move on to his respiratory rate. As I'm talking to him, I am counting. So you're multitasking all the time. So as I'm talking to him, you said 16, right? That's also within normal limits. Now I'm going to ask him, what brings me today? Why did you call me? He's going to tell me shortness of breath or chest pain. That's sharp onset, correct? He's going to be like, oh, my chest is hurting. I'm going to ask him if he took anything and is he allergic to any medications. That way I can know if I can administer medications, and if so, that I'm not causing him to go into anaphylactic shock by giving him something that he's allergic to. So, not in this case, but if he do say, oh yeah, I already took my nitro, now I gotta assess his BP and everything again before I give him another tablet, just to make sure that he doesn't go lower than the normal limit. His blood pressure is
96/82.
So he has a narrow blood pressure, but he got chest pain. The other part of it, BP post.
You want me to reread it?
Yes, please.
SPO2.
A 62-year-old male collapsed at a family member's funeral. He complains of shortness of breath and sudden onset of sharp chest pain. His skin is bluish gray. His vital signs are pulse 108, respiration 16, blood pressure 96/82, and SpO2 85. One room air.
So I missed that bluish gray skin the first time. He got bluish gray skin, which means he's cyanotic. And his SpO2 is low, which means he's hypoxic as well. He's not breathing adequately to get the blood flow, the oxygen to his blood flow to perfuse his face and stuff. So now that I have that information, I would take him with his thing, since it is low, with his SpO2 being low. You said 85. I would go non-rebreather, because the nasal cannula, he's too low for that. He needs more oxygen. Putting on the non-rebreather, ask him if it's comfortable, if it's tight enough. You tighten it from here and make sure it's on there. Some people can't tolerate it. Other people can. If not, you could just ask them to hold it up to their face. They breathe when they need to. But since he is so low, I'm going to advise him not to touch it. Just take in the air, sir, deep breaths. And then I would transport. There's nothing more I could do with him on scene.
So, before you transport, what do you want to do? You want to get on your telemetry radio. You want to tell the hospital what you got. Have a 62-year-old male. You give them all the vitals, right? You can inform them what you got so they know what they're expecting, right? What is one of the things that can happen to this patient while we're en route? They're not really stroking. Their blood pressure is not in a stroke neighborhood, right? If you're going to be stroking out, your blood pressure is going to be what? Right. If it's low, it's going to be what? More bleeding, some type of internal bleeding, right? So if it's high, you're looking for, then you're worried about strokes.
Yeah, you're thinking about like a heart attack or something.
Correct. You're looking for a heart attack to be your next step, right? So while you're en route, you want to start preparing in the event that he does go down, that you're good to go, right? You want to make sure that your AED and your ambulance is close by you, or that you can get, if you got to go to work, you can go to work. You know what I'm saying? So, but again, if his blood pressure is high, now we're talking stroke. Now he or she may be stroking out, but right there on the low end, we're looking at heart attacks. Make sense?
I didn't know because I transported.
And then he was hypoxic too, so
Right.
yeah.
So it's at 5 points.
Yeah. Yeah.
You ain't do too good.
So, and then we didn't talk about that, right? So there's two things. What if they're in respiratory arrest or cardiac arrest, right? Heads up, listen up. We talked about this. He can go in route, he can go in respiratory arrest, or he can go in cardiac arrest. If it's respiratory arrest, what do we want to do for him? Exactly what we're doing. We're going to breathe for him. Got it? If it's cardiac arrest, we're gonna go into CPR.
Okay.
Got it? Respiratory just means they're not getting enough oxygen. They're losing their oxygen. They're losing their ability to breathe, right? Cardiac means we lost the heart and now we need to do this. But if they're in respiratory arrest, we're gonna remove this and now what are we gonna do? Got it?
Okay. What's the difference between arrest and failure?
Respiratory is your air. Cardiac is your heart.
Well,
Arrest
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 is
is
completely
consist.
different. Failure is like the
Failure.
difference between distress and arrest. Like it's like when you see failure, if you don't intervene quick, they will go into
They will go
arrest.
into
So
cardiac
it's just
arrest.
worse than distress.
It's worse than distress, yeah.
Yeah.
Because the stress, like if I climb up these steps and stuff and the oxygen is not good, I can be in distress. But failure is like I'm really struggling, and
Yeah.
arrest is, yeah,
Yeah, you're gonna know. He or she gonna be letting you know
definitely.
yeah, you won't be guessing.
So Imani did good, but she didn't do great,
I forgot.
and she forgot a couple things. Cause remember, she's being precepted. So in
Okay,
this-
wait, before you answer it, why don't you ask the 3 students that's getting ready to take what she missed?
Oh, okay. What did Imani miss? What did she miss before when she first got on the scene? How about that?
No, I did figure out how to say
She didn't see if she needed to call for additional resources.
Call 911.
Yeah, I didn't.
Request for ALS, tell the number of patients, identify MOI, NOI.
She forgot to put them in C-spine because he collapsed. Or the chase, yeah.
Well, let's back up. Because he collapsed doesn't mean he gotta go into C-spine. He's only going in C-spine if his fall caused him to have trauma. Just because he can't breathe or having respiratory problems doesn't mean he goes into C-collar. We don't treat him like that. We only treat you like that if you have trauma, right? So that's why I wanted everybody to start thinking, because if you get a question like that and you go and put C-spine, you're gonna be wrong.
Oh yeah.
Because I have to tell you, the question has to tell you that it's trauma, right? Don't make the question up. Most of us read too much into it. We make up some stuff in our head that's not there. You know, and you gotta be careful of that.
Well, on the assessment it says considers. So she should.
It's just a
It's just-
consideration,
it's
that
a
don't mean
consideration
do
that
it.
You have to do it, yeah.
It's a consideration.
For the primary assessment, she did really, really good. Oh, what did she miss? Did she miss anything? I'm sorry.
Determine the alertness, AVPU, ANO.
She did it.
Oh, I didn't announce it, but like him talking to me, that was my. Well, yeah, I should have asked the date, president. You're correct.
Sample.
I asked her if she was allergic.
She did that.
Okay. What about the second assessment?
Take another set of ice.
Cause I just said.
So a couple of things, right? So if he's talking to me and he's answering my question, I'm not gonna ask him what day it is, right? Cause I'm talking to him. He tells me his name, right? So I don't have to ask him what day it is or do you know who the president is, right? Because that's not the problem he's in. That makes sense?
Yeah.
So he's alert and he's orientated that he can say, hey, I'm John, you know, if you read the question through it. That's what I'm talking about, adding stuff and making stuff up, right? I didn't need to ask him all that, because he basically was telling me what his issues were. So he was conscious enough to let me know what his problems. I never showed him the breath. You feel me? So in that question, it answered a lot of those questions that you don't start reading into it. Don't add anything to the questions. Most everybody get the questions wrong because they start reading into it. They start coming up with their own analysis, right? You're not the doctor, you're the EMT. Stay in your scope of training. Make sense?
Do you have a question?
So would you ask like, hey, what's your name, date? Like, would you ask that in just trauma, or can you ask that in both medical and trauma?
It depends, because most times trauma, they're unresponsive, so you're
Okay.
not going to get anything from them. But you can ask the surrounding people that seen it, like, hey, do you know this guy, and stuff like that.
So what if they do have like trauma, but they're responsive? Like,
Then you would ask.
Okay.
Yeah. If they can talk to you, talk to them.
okay.
But if they can't talk to you, try to find somebody that witnessed it to try to see like what happened.
Okay.
So, for example, if I walk up on this guy, my thing is like, hey, are you okay? Now, what's your name? John. Do you know what day it is? Now I want to ask him that, right? But if I walk up and say, hey, what's your name? Oh, my name's John. What's going on, John? I got a shortness of breath. How often you had? How long was your onset? When did it start happening? Oh, about 2 days now. This is the third day. And every call you go on, this shit happened 2 or 3 days. Today is the day at 3 o'clock in the morning that they had to go to the hospital. Yeah, so just remember that. Yeah, this has been going on for 3 days, but at 3 o'clock in the morning while you were asleep is the time he decided he needed to go. And they go to the hospitals from 2 o'clock in the morning to 5 o'clock because they think nobody's there. They don't realize that's the time everybody goes.
Can you
So-
share your secret about writing the vitals on their rubber gloves?
Oh yeah. So just FYI, like a lot of times when you're taking their pulse and stuff, you'll just take your glove and you'll just be like writing everything down on your glove. Because here's the thing, right? When you go back to put all of this information in the computer, your time on scene, right? So we have in the future we'll give you our ESO, which is our PCR, right? And then you'll kind of go through it, and you'll literally have to fill that out. But you're not going to remember all of this in your head, right? And one of the reasons we're writing it on our gloves as we do. Did you guys do that yet?
Yeah.
Did you get trained that way?
Yeah, I do the same thing.
That's what I'm saying. So most of it, so we got a lot of EMTs in here.
These no.
I got an issue about that glove thing,
Yeah.
because you gotta throw your gloves away, cross-contamination, all that stuff. It is kind of a discretionary thing, whatever you prefer, just make sure you keep up with it. There's many ways you can do it. You can keep like a small little sheet of paper in your pocket or whatever, make sure you jot it down. What I used to do on my ride times with the city, I used to take a strip of tape, sit along my thigh, and then write everything I need right there. That is not going anywhere. You can just speak everything right off of that.
Right. Everybody got their methods. We came up in the era where you wrote it on your glove, right, and we kept it. That's the era we came up in. Everybody, you're gonna work. People got methods that they use. You'll figure out what works best for you. The glove always worked good for me, right? I wrote everything down on the glove. So when I was in the back and I was doing the computer work, right? Because remember, I got time to do this. So while we're en route, right? He's sitting in there. So now I'm at the thing and I'm looking and I'm going. As I'm doing my thing, I'm looking. I'm putting it all in the computer. And by the time we get to the hospital, all that's done. When I change gloves, it don't matter. Why? Because I documented everything. So that's why we use the gloves. Because we're sitting there with him riding in the back. While I'm sitting there, I don't have nothing to do but what? Get all this data put in. Because when I get to the hospital, I got to transfer that over to the hospital so that they have that information. I'm not going to wait to get into the hospital and start doing all this stuff. Now, there's things I'm going to do in the hospital. I may do the narrative in the hospital. But the baseline, when I get there, they're going to have, I can give them the baseline right away. And then I can go in and do my narrative and then download the report right to them and I'm out of there. Change my sheets, we gone. Make sense?
Yes.
Also, before you transfer, while you're still in the ambulance, you want to take another set of vitals just before the hospital and the nurses take over and do their set. Just so you can see if he changed, if your interventions actually worked, or if he stayed the same. That way they know what to do from there.
Especially on the national level. On the city level, we pretty much don't, because there's really no time. We're within 5 minutes of any hospital we need to go to, right? You're not going to be in that ambulance. If you're in that ambulance 10 minutes, that's a long time in the city. Now, when you go out to rural areas, you may be in that ambulance for 30 minutes before you get to a hospital, right? You're going to do 2 or 3 vitals by the end, right? You're going to be checking vitals and updating them probably every 5 to 7 minutes, you know what I'm saying? Based on the condition of your patient. Or sometimes you may just be talking to you, hey, Mr. Jones, how you feeling? Well, you're looking great, so that's good. And you'll be encouraging him and shit like, don't die on me yet. You know? No, you don't say that, but you keep encouraging him. You keep him communicating, you know what I'm saying? You keep communicating with him so he's not, he or she. But you gotta understand, a lot of people get nervous once they get in those ambulances and stuff. And your response, because you like, oh man. You know, you can't say that, right? Now, so So now they're thinking something's really, really wrong with them.
Yeah.
You know what I'm saying? It may not be. You know, so you can actually mess up their psychic and how you respond to it. You know what I'm saying? So even when you see stuff, and you're gonna see stuff that you like, you gotta remember, like, because they think their arm is still there, they don't realize it's gone. You know what I'm saying?
So speaking of condition and vitals, how often are you supposed to check the vitals with somebody that's stable? 15 minutes. Somebody that's unstable, how often do you take the vitals? So just keep that in mind. 15 minutes, if you got like a 10-minute transport, it may do your diligence to check it again before you get in there, but not necessarily. There's not gonna be much of a change if they're stable like how I am right now. Like I'm just talking to you all. My blood pressure may be 130, that's because I'll run a little high. You don't have to take it again if, I'm just up and ready. But if you got somebody that's dozing off and their status changed from when you first got to them, okay, maybe I need to check something again. Just keep that in mind.
I would say always keep the post ops on them just
Yeah.
get.
Post-op is going to be your bestie for the rest of your career. Whenever you transport a patient, because you could be sitting there and they could be on this oxygen, and out of nowhere they fall unconscious. But when you have that post-op on, it's gonna tell you when they go from 94 to 92 to 85. So even when I'm on an ambulance and I'm writing a report, I say, before we go en route, all right, let me just take the blood pressure one more time, get my set of vitals, and I put this post-op on. I may take the blood pressure cuff off, and they be like, well, you taking this off too? No, I'm just gonna keep it right here, and you just rest your hand on your lap, and that's it. And as I write down my report, I'm looking every 5 minutes. Start a conversation if they feel awkward. Sometimes when you coming from University of Chicago all the way to Christ, it's gonna be a nice little ride. It's gonna be a little bumpy. If you want to make them feel better, you tell the driver, hey, if you got a pothole coming up, just give me a heads up. Like little things like that. So, post-ops, bestie for the rest of you. Don't forget it.
Any other questions?
This was too much for us over here.
Certified to everybody else. Cut it out.
I got something. Okay, so like before you get dispatched, you would get like a little summary or whatever. That can like give you an idea of what to ask when you get there.
Okay.
Like if it say like just chest pain or something, then you just like you would know what type of questions you will have before you get there. Versus like if you just got like a thicker.
Sometimes
Well,
it's
sometimes
Sometimes
it's not
dispatcher
true, yeah.
tell you got a shortness of breath and they got a history of stroke. Like the thing is you will never really know what you're getting yourself into until you get there. Because you can pick a patient up from the hospital and they say that they getting discharged. But you get there and their blood pressure is 208 over 97. You know what I'm saying? You can't transport that patient. They may have just came in to get a Foley change. But whole time now they're hypertensive and they got a history of high blood pressure and haven't taken any medication. You can't transport that patient. You know what I'm saying? So dispatch will give you an idea of what's going on. Dispatch told me one day I was picking up a 64-pound patient. They were almost 200 pounds. So don't depend on dispatch to give you anything accurate. Just be ready when you get on scene for anything they tell you to not be true.
In a picture perfect world, that is how you want chest pain, how you want chest pain. I've gotten calls where it's difficult to breathe, and 5 minutes later I'm delivering the baby in the back end.
Yeah.
So you just gotta be prepared for what's gonna be in front of you. Like the patient will tell you everything you need to know. Somebody else probably made the call. Oh yeah, they have chest pain. Meanwhile, they probably have an asthma attack or something, or they got a bad diarrhea. So just talk to the patient when you talk to them. Sometimes family members may be able to help.
It depends. Nobody know you better than you.
Alright, that's it.